Welcome. Thanks for joining us today for this educational session on managing the impact of bladder cancer treatments on sexual function and intimacy for female patients. My name is Dr. Melanie Altaz. I'm a gynecologist and a sexual medicine physician at the BC Cancer Agency as well as at the BC Centre for Vulvar Health here at Vancouver General Hospital. First of all, I want to applaud each of you for attending this presentation. This can be a time of many changes and challenges, which can be emotional, physical, or psychological. Hopefully, the knowledge that we share today will help to empower you in your cancer journey. So part one, we're going to focus more on a medical and a biologic approach to sexual function. So we're going to go over what is normal sexual function and what is the impact of bladder cancer treatment on sexuality. We're going to touch a little bit about menopause, and we're going to go over management approaches for all of these things. If you also join us in part two, we're going to talk more about a psychological approach. We're going to go over sexuality and intimacy, communication strategies. We're going to dive in a little bit to sexual desire and arousal, and also touch on body image. Here are the different education modules that we offer, and they are offered either in person or through live online programs. Most of these educational sessions are offered every month or during the clinic. So if you are interested in learning more about one-on-one appointments or our other educational modules, please get in contact with the program coordinator. And that information you'll find on the last slide of these presentations. So in the Sexual Health Clinic, our goal is to provide education, supportive care, and medical and surgical therapy in order to enhance your sexual functioning, intimacy, and overall quality of life. So why should we talk about this? Well, sexual health is important for overall quality of life, and many women feel unprepared for these changes as they're going through their cancer journey. Knowing what to expect helps you to make informed decisions. So we're going to cover a lot of information today, but some of the common questions that we hear in the clinic are, will I still be able to have sex? Will I still feel pleasure? Will I feel different about my body? And how can I talk about this with my partner? So let's start off by talking about what we mean about sexual health. Well, sexual health is so important that the World Health Organization has put out a statement saying that sexual health is fundamental to the overall health and well-being of individuals, of couples, families, and community. And this depends on the access to good quality information about sexual health, the ability to access sexual health care, and also living in an environment that affirms and promotes sexual health. And we know that sexuality is important to cancer survivors. In 2010, the Livestrong Foundation did a survey where sexual dysfunction ranked as the third most common concern for people who had gone through cancer treatment. The first and second, which you may also resonate with you, were energy and memory. So what happens if we don't address sexual well-being? So we see in general an overall decreased quality of life with associated and increased distress. There's lower long-term adjustment to life changes. We see increased depression and anxiety. We see poor psychological adjustment, both in the short and the long term. We also see an overall lower life meaning. And we also see that people who have sexual distress will have difficulty coping with other side effects of the cancer and/or the treatment. And I think we're in a shifting landscape where medicine is understanding and starting to value sexual well-being. So because of that, and because sexual health is really important, you would think that we would be managing this really well, but we're actually not. So what gets in the way of us prioritizing and addressing sexual well-being in the healthcare system? So I would divide these barriers into patient barriers as well as provider or physician barriers. So from a patient perspective, there can be what I would say are self-centered, so patient or inward focused barriers. And these are things like not having the language or the words to kind of clarify the impact of the treatment on your sexual well-being. So basically you don't know how to say what you're feeling or say what your concerns are. These can also be provider-centered. So some people will think that their physician is not comfortable talking about sex or sexuality. They may think that their physician will be embarrassed if they bring things up, or that their physician won't know how to answer their questions. And that may change the doctor-patient relationship. From a physician perspective, we also have barriers. So there are time constraints. So we have a short period of time to spend with patients during their appointment. In medical school and residency, physicians are not taught a lot about sexuality, and in particular, women's sexual health. So there's a limited knowledge and training. There can also be a lot of assumptions about a patient's sexuality and who sex may or may not be important to. And some of the biases that I see are physicians assuming that someone who's older, maybe in their 70s, 80s, or 90s, that sexuality is not important to them. Or maybe someone who has advanced disease, like metastatic disease or is in palliative care, that sexuality is not important to them. And that's not always true. So let's talk specifically about bladder cancer and the treatment. So the treatments for bladder cancer can impair the vaginal length, so it may shorten the length of the vagina. It may change the genital sensations and lubrication, and thus impacting global sexual functioning and intimacy with one's partner. So today we'll start by creating some perspective with information about intimacy and sexual functioning. And a lot of this information will seem really specific to partnered relationships, but most of it can pertain to you, even if you're single, if you're dating, or if you're not sure you're going to be interested in finding a new partner. Let's zoom in on sexuality, because it's actually a lot more than just having sex. So sex is something that we do. It's a behavior, it's an action, but sexuality is a part of who we are. So it's how we experience and express ourselves as sexual beings across the lifespan. And it can include desire, pleasure, intimacy, touch, body image, emotions, values, and identity, including sexual orientation and gender. It can also include relationships, communication, and cultural and spiritual influences. So sexuality can be expressed with a partner or on your own, and it can change over time, especially during and after cancer treatment. So there are many ways of being intimate with one's partner, and it's important to communicate what dimensions of intimacy are important to you and how to maintain that closeness throughout your relationships. So intimacy can be a bit broader than sexuality. So it's that felt sense of closeness, of safety and connection with someone or yourself. And it doesn't always have to involve sexuality. So this could be within other relationships, with a family member, with a child, with a parent, or with a close friend. So intimacy involves things like emotional closeness, affection, even just being seen and understood. This has a lot of associated emotions like trust and vulnerability, comfort, and reassurance. It can involve non-sexual touch like physical affection, holding each other, cuddling. And there can be a lot of overlap between sexuality and intimacy. So sex can be one way that someone expresses intimacy. And intimacy can strongly influence sexuality, so that feeling of being safe and close often help desire and arousal. But they're not necessarily the same thing. So you may notice in this bubble that in this picture, each of the bubbles is equally represented, but this is not always the same for everyone. So by intellectual intimacy, I mean that feeling challenged, feeling aligned in the way that you view the world. There can be emotional intimacy and experiential intimacy, so sharing of experiences. So let me give you some more specific examples. So with partnered relationships, sexuality goals may include things like what pleasure looks like now, and what changes are medical or technical versus emotional, and what adaptations do we have to make to bring sexuality back into the relationship. Whereas intimacy goals could look like things like staying connected while you grieve or adjust to changes, renegotiating the rules within a relationship, and rebuilding confidence. So some of the key messages can be things like, we're learning what works now. We can expand what counts as sex, and we can expand what counts as closeness. So if someone is single or dating, some of the sexuality goals may be things like reclaiming your sexual identity after treatment. What does solo sexuality look like for confidence building? Some intimacy goals can be things like intimacy with self, so developing self-compassion and body acceptance, as well as deciding what future relational intimacy will look like. So how and when to disclose to a partner, what do boundaries and safety look like? So you can rebuild sexual confidence and intimacy confidence before you even have a partner. So what are some of the things that I hear in clinics specifically? So we may see direct changes to sexual function. So things like the experience of menopause, which may or may not come as you go through your treatment for you. So menopausal symptoms can have a big impact on sexual dysfunction. So things like hot flushes, night sweats, joint muscle pain, changes in weight, sleep disruptions, mood, such as anger, irritability, depression, and even quick changes between those types of mood states. Vulvovaginal health can be directly impacted from surgery, so you may have scarring, adhesions, you may have a shortening of the vaginal length, or also vulvovaginal health can be impacted by menopause, so it may cause a dryness, a thinning of the skin, a decrease in elasticity. Sexual desire can change due to a lot of contributing factors, but you may also see changes in arousal and genital sensation, so a decrease in sensation or shifting in sensation. There may be changes in relationship to self, such as body, image, and sexual identity, and there can be changes in relationship to others. So your current or future relationship, there may have been a shifting of the roles into caregiver. Roles can particularly be impactful in sexual desire. Societal beliefs, and I see this a lot around society telling us what's normal and what's not, as well as a shift or a change in relationship roles. So let's start off by going through the female anatomy and what happens during surgery when the bladder is removed. So if we look at this image, this picture is, if you imagine if we cut someone down the middle and we look at them from the side. So what we see is the bladder, which is that hollow balloon-shaped organ. It's located in the lower part of the abdomen. It's right, if you can touch your pubic bone, the bladder is located right behind the pubic bone. Directly behind the bladder, we see the vagina, and at the top of the vagina is the uterus and the cervix. And directly below the vagina is the rectum and the anal opening. So when someone undergoes surgical treatment of bladder cancer, we call this a cystectomy. So a radical cystectomy is removal of the bladder and the surrounding lymph nodes. In women, the top part of the vaginal wall and fallopian tubes are often removed. Some people may also have removal of the uterus, so we call that a hysterectomy, and they also may have removal of the ovaries, depending on the type of cancer. And there are 3 different types of urinary diversion, so something we call an ileoconduit, a neobladder, or a continent cutaneous diversion. So a radical cystectomy for bladder cancer may involve removing the bladder, uterus, ovaries, and part of the vagina. So you can imagine that's a pretty big surgery. So some of the symptoms that we see may be the symptoms of menopause, particularly if the ovaries are removed, because it's the ovaries that are responsible for making the female hormones. We may see shortening of the vagina, we may see scar tissue in the vagina, or dryness due to the hormonal changes. There may be less lubrication, changes in sensation, as well as the emotional impacts such as body image, confidence, intimacy, and even just an unknown of what does my vagina, what do my internal organs look like right now? So anatomically, if the anterior, so the top part of the vaginal wall is removed, this can reduce the length, scarring, and it can cause painful sex and maybe even prolapse. So that's when there's a relaxation of the walls of the vagina. If there's a urinary stoma, there could be a change in body appearance and confidence. There can be the surgically induced menopause if ovaries are removed. There may be changes in the nerves that are supplying the pelvic floor. So this may impair sensation by injury to these nerves. There may also be an impact on blood supply to the pelvic area. So when removing the bladder, some of the blood vessels going to the pelvis and vagina can be compromised. So this decrease in blood flow may contribute to the dryness and to the sensation of desire and arousal. So let's go into how to manage these side effects and sexual consequences. And how do we move forward? So I'm going to give you some tools and some strategies that are going to help you in this area. When people are referred to me, I often get asked, are my sexual problems biological, medical, or psychological? And in reality, that's kind of a false dichotomy that's really difficult to make. So it's not quite so black and white. And I find there's a lot of overlapping factors between all of these potential contributing areas. So it's really important when we're talking about female sexual health that we look at the biology, so the medical changes that occur, that we look at psychology, what are the possible contributing factors. And we also need to look at this in the context of the society that we live in. So what I want to do for the next part of the talk is talk about, just give you education. So education and knowledge in itself can be very empowering. So knowing what's normal, what's common, and what's not. We're going to talk about medical treatment, so using over-the-counter products as well as some prescription options. I'm going to talk a little bit about some surgical approaches. We're going to talk about how you can access these resources through the Sexual Health Clinic in the BCSC program. So let's start off by talking about vulvovaginal health. So we're going to touch on lubes and moisturizers. So we're going to talk a little bit about some pelvic floor physiotherapy or some physical exercises that you can do. And I'm going to touch on a little bit around menopause. And all of these things are really important. They're all contributing to each other, and all of these strategies are going to help you move forward in regaining your sexual well-being. So let's start off by looking at the changes that occur in the vagina. So we used to call it vulvovaginal atrophy, but now we call it genitourinary syndrome of menopause, or GSM. So these are the changes that occur in the vulva and the vagina due to changes in hormones. So either if you go through natural menopause, where the ovaries stop making estrogen, or if your ovaries are removed as part of the cancer treatment. This estrogen deficiency leads to a thinning, a dryness, and an irritation of the vulvar and vaginal tissue. So this may cause a daily discomfort. So such as, if you're walking, wearing tight clothes, or biking, you may notice an increase in discomfort in that area. It can also lead to painful sex. It can lead to a decrease in sexual sensation, arousal, and it can also lead to urinary symptoms. So we diagnose the genitourinary syndrome of menopause basically by self-reported symptoms. So there's not a blood test to be done or any other investigations. So if you're experiencing these are consistent with a diagnosis of GSM and can be confirmed by examination of the tissue by a physician or healthcare provider. So I'm going to show you an image on the next slide. So this is the vulva or the external genitalia. So we commonly think about estrogen leading to health within the vagina. but it's also a really important hormone for the external genitalia, and particularly the vulvar vestibule, which is the tissue on the inner lips of the labia minora. So when we're treating low estrogen, it's really important that we treat this part of the body as well as inside the vagina. So let's start by what I call in the moment treatment. So these are going to be things that you can use during sexual activity that can help with this low estrogen, these sensations of atrophy. And these are lubricants. So not all lubes are created equal. If you go to the pharmacy, what you'll see is mostly water-based lubricants. And these are not the best lubes to use during menopause or when you're experiencing changes in sexual function, and I'll go through why. So this is a period of time where it's important to explore silicone or oil-based lubes. So let's look first at the water-based lubricants. So again, these are the most popular ones. You go to the pharmacy, this is pretty much all you're going to see. The real only advantage of water-based lubes are that they're non-staining and they're a little bit cheaper. The drawbacks, though, is that they can dry out quickly. Some of the preservatives in water-based lubricants can cause irritation. These are things like glycerin and propylene glycol. When you're considering using a water-based lubricant, you need to take into account two different properties, and these are pH and osmolality. You may remember those from high school chemistry, but if not, I'm going to go through what those mean on the other slide. So when we look at pH, the healthy premenopausal vaginal pH is about 3.8 to 4.5. If a water-based product has a low pH, it can be really irritating to the tissue. So a low pH means that it's more acidic. A high pH, which means more basic, we sometimes see an increase in yeast infections as well as something called bacterial vaginosis. So for water-based products, there's very few that are within that proper pH. A lot of them are lower, so slightly more acidic. So if you've used water-based lubricants and you've put them on and you felt that they caused irritation, it may be because of the pH. The second thing we need to take into account is something called osmolality. So if something is hyperosmolar, what this means is when it's put on the skin, it's going to draw water out of the skin. And this is so important for water-based lubricants that the World Health Organization has given a recommendation for the upper limit of what's acceptable for water-based products. And there's actually very few that are within this range. So if you are using a lube over and over again that is hyperosmolar, it's going to keep drawing water out of the skin. So if you're already experiencing dryness, you can see how using these products may not help in the long term. So for these reasons, we recommend using silicone or oil-based lubes. So a really good silicone lube to use is called Uberlube. Another one is ID Millennium. For oil-based products, there's a lot of companies that will make plant-based oil lubes, but you can just actually use coconut oil. So the cooking coconut oil, the unprocessed, unrefined. If you do want to use a water-based lube, these are the brands that are usually pH and osmolality balanced. But again, many of them are not. The one thing to remember with silicone or oil-based lubes is you use a very tiny amount compared to water-based, and to keep in mind that they can stain. So just be mindful of that. So those are things that you use in the moment. But what can you do on an ongoing or preventative basis? So, and I call these moisturizers. So these are things that you need to use on a regular basis. Using them once a month, a couple times a year, it would be the same if you were using moisturizers on your hand or your face. They're not going to work. So you need to use them regularly. We have non-hormonal options and we have hormonal options. Let's start by going through the non-hormonal ones. So what you want to do is look for vulvar vaginal moisturizers that contain hyaluronic acid. And you may have heard of these before because a lot of dermatologists will use these for face creams. Well, it works really well on the face, but it also works well in the vulva and the vagina. These are some of the examples. So I want you to look on the right-hand side of the screen, because these are the ones I recommend. So we have Feel Amazing, is hyaluronic acid and vitamin E. You can get this from Pure Pharmacy. Repagyne are suppositories that contain hyaluronic acid, and Gynatrope also contains hyaluronic acid and vitamin E. You can get Gynatrope from Costco, and you can get all of these online. The one on the left-hand side is probably the more popular one, or the one that you would find very easily in the drugstore. It's called Replens. This does not contain hyaluronic acid. I don't recommend using it. It has a very low pH and a high osmolality. So stick with the ones containing hyaluronic acid, and these are just examples. There are some other ones that are available. However, what I do recommend for people with sexual pain who have non-hormonal cancers, which bladder cancer is non-hormonal, just go right to using an estrogen cream. So people who have hormone-sensitive cancers like some breast cancer and some uterine cancer, I would highly recommend trying the non-hormonal options first. But if your cancer is not hormone sensitive, then just go right to the one that's going to work and the one that's very safe. And these are topical hormones. So, and by topical hormones, I mean estrogen. So we have a lot of different ways that we can deliver estrogen to the vulva and the vagina. We have tablets, we have suppositories, we have creams, and we have a ring that goes inside the vagina that you change every 3 months. And we also have something called intrarosa or prosterone, which is a derivative of testosterone that's converted to estrogen within the vagina. So these are all of the hormonal options. We have a lot of them. We know that they're very, very, very safe. They truly act as moisturizers, so they just are absorbed into the tissue. They don't get absorbed into your bloodstream. Even for people who have hormone-sensitive cancer, so if you have breast cancer, uterine cancer, these are also very safe to use and don't increase the risk of cancer recurrence for those cancers. So for bladder cancer, just jump to using these. And I do just want to remind you that when you decide to use both the hyaluronic acid and the estrogen or hormonal products, that it is really important that you do treat the vaginal opening, so the vulvar vestibule, and you also treat the vagina. I see a lot of people in my practice who have been prescribed estrogen, and they're referred to me because they're told that it's not working well. They're using it, but they're having ongoing sexual pain. And when I talk to them, their pain is around the vaginal opening, so it's more external, and that's not where they're applying the estrogen product. So it's really important to treat both of these. So what do you do if you've tried using the hormones or the topical moisturizers and you're still experiencing sexual pain? You may have an examination by the physician who tells you that, maybe there's some scarring in the vagina, maybe the vagina has become a little bit shorter, or maybe there's pelvic floor dysfunction. And by that I mean maybe the muscles in the pelvic floor are really tight. And that's something we can see after surgery. When the muscles tighten to actually just protect yourself from that experience. So your physician may talk to you about exploring pelvic floor physical therapy. So the photo I have here are what I call vaginal inserts. You may also hear the word vaginal dilator or accommodator. There's a lot of different words that people use. And these are inserts that you insert into the vagina that can help prevent scar tissue from forming. This is another way that you can use these. If you have really tight pelvic floor muscles, it may be recommended that you use a vaginal insert to retrain your muscles. So if you're inserting this dilator or this silicone probe, you can work at releasing the muscle tension around this insert. And for these, you can use these on your own, but I would recommend physician guidance, or you can explore using pelvic floor physiotherapy. And there are a lot of pelvic floor physiotherapists in British Columbia who have experience with post-cancer treatment and people who have pelvic floor dysfunction. I have on our website at the BC Centre for Vulvar Health, we have a buying guide for different vaginal inserts. So we have online and in-person options if you want to go to a local store. We also have pricing as well. So you can go to our website at bcvulvarhealth.ca and take a look at these handouts. Another device that I frequently recommend is called the O-Nut. You can purchase this online. This device is really good for women who have shortening of the vagina. And these are very, very soft rings that would go on the base of a penis and customize the depth of vaginal insertion or vaginal penetration. So these are good for people who would have deep pain at the top of the vaginal vault. Some other treatment strategies that your urologist may have explored with you, or that you could talk to your urologist about, or any of the providers within the sexual health clinic, are surgical options. So pre your initial surgery, your doctor may talk about or consider nerve-sparing cystectomy to decrease the impact on the nerves to the pelvic floor. Organ-sparing cystectomy, so if they're talking about removing the uterus or the ovaries, and also preservation of the urethra. Post your cancer or initial surgery, your doctor may also talk about vaginal reconstruction. So these are for people who have shortening, adhesions, scarring within the vagina. There's some strategies, surgical strategies, that your urologist may talk to you about or recommend. So let's talk a little bit about menopause. So within the context of this talk, we don't have the capacity to go into a huge amount of detail about menopause, but I do think it's important to touch on this because it has a huge impact on sexual function. What is menopause? Well, you are in menopause when you've had 1 year without a period. And so that's for people who go through menopause naturally. Let's say if you've had your ovaries removed, though, as a part of your cancer treatment, that basically you're in menopause at that time. You don't need to wait for that year to qualify for being postmenopausal. When someone has their ovaries removed, or when the ovaries stop working, there's a significant decrease in the female hormones. And the main ones are estrogen, progesterone, and also the ovaries make a little bit of testosterone. Some of the menopausal symptoms that we see, we classically think about menopause as being all the hot flushes and having an angry, irritable woman. And it's a little bit more than that. There's a huge list of symptoms that people may experience when they're perimenopausal, so starting to go through menopause, and when they're in menopause. We typically see a lot of sleep interruptions, like maybe related to hot flushes. But also we'll see sometimes there's a lot of anxieties people go through menopause, or sometimes we may not even know why your sleep is interrupted. We see irritability, anxiety, depression. Sometimes people experience headaches. I hear a lot of people talk about concentration and memory issues, joint or muscle pain. And you can imagine if you're experiencing all or any of these things, how it would significantly impact your sexual self-image, your body image, and also your wanting to desire sexual intimacy. So what are the indications for treatment? So it depends on where you live. So in Canada right now, hormone therapy is only indicated for bothersome hot flushes or night sweats. The United States has added on another caveat for the prevention of osteoporosis, so if people are at high risk of osteoporosis. But when we look at what do other countries say, they say that you can treat someone who's having bothersome hot flushes or night sweats, but that it may also help with other menopausal symptoms. So it may improve mood, stabilize mood, it may improve sleep, even sleep disruptions that are not due to menopause, may improve joint muscle pain as well as sexual function. So in my practice, and I think a lot of menopause practitioners will treat people even if hot flushes are not their main symptom. But we do know that hormone therapy decreases the frequency and severity of hot flushes by more than 75%. So it's very significant. Ideally, we want to start hormone therapy when someone is under age 60 or within 10 years of them going through menopause. And the reason for this is because if we start hormone therapy when someone is older or remote from menopause, we may see an increased risk of heart or cardiovascular side effects. If you have had a hysterectomy or if your uterus has been removed, you only need to use estrogen. If you have not had a hysterectomy, then you do need to take estrogen and progesterone. And progesterone just helps you protect you from the side effect that we see with estrogen by itself, which may increase the risk of uterine cancer. So progesterone is protective. We have a lot of different ways to deliver estrogen. You can take estrogen as a pill, or you can take it by something we call transdermal, where it's absorbed through the skin. And this could be as a patch or as a gel. I prefer when someone has an impact on sexual function, I actually prefer to deliver it via a transdermal route. When people take estrogen as a pill, it actually can decrease their sexual desire. So transdermal, we see an improvement in sexual function. If you have not had a hysterectomy, you do need to take progesterone, and these can be taken as a pill, or you can also use an hormonal or progesterone IUD. So we primarily prescribe progesterone to people to protect the uterus from uterine cancer. If someone was taking estrogen by itself, it would increase the risk of getting cancer of the uterus. However, even in people who've had a hysterectomy, I may sometimes prescribe progesterone because it can also help with sleep or mood. This module, we're talking about sexual function and sexual desire. So a common thing that comes up is, what about testosterone for women? So testosterone for women for sexual dysfunction is not approved by Health Canada, but we still do use it. There's a lot of research that supports the use of systemic testosterone for female sexual desire in women who are going through menopause, so perimenopause, and for women who are postmenopausal. We want to use a very tiny amount of testosterone, and it's transdermal, so it's a gel that you take 2 to 3, 4 times a week. You need to monitor it very closely. We want to keep the testosterone levels at a very low level to prevent male side effects, so things like changing of the voice, balding, acne. And if you use it for 3 months and you've not seen any improvement, then we recommend discontinuing it. So how can you advocate for yourself? So I see a lot around menopause and particularly around sexual function because physicians were not taught this in medical school and residency. I see a lot of physicians, and this may be family doctors, urologists, gynecologists, who don't know a lot about sexual function and menopause. So I see a lot of people who struggle with these symptoms and are having a difficult time accessing care. So specifically for menopause, if you go to, these are 2 amazing resources. So if you go to a website called the Menopause Society, so it's menopause.org, you can go and search for a certified menopause practitioner. And they have a list of a lot of people within British Columbia, within North America and outside North America who specialize in menopausal care. You can also go to the Canadian Menopause Foundation at menopausefoundationcanada.ca, and that has a lot of information for women on just general menopausal symptoms. If you have questions about any of the other things that I've talked about today, you can definitely reach out to the program coordinators for the Sexual Health Clinic. You can also get a lot of support through the British Columbia Bladder Cancer Support Group, Metastatic Bladder Cancer Support Group, the Women's Bladder Cancer Support Group, specific to bladder cancer, but also the Canadian Cancer Society will have a lot of information for you as well. An organization that I really love it's called Inspire Health. This is a BC-based organization that provides complementary and supportive care to anyone who's going through cancer treatment. So just in summary, where to begin? Like what can you do with all of this information? And I think what's important is that you talk about the changes and how those changes make you feel. So even if you feel you don't have the language or the words, I would encourage you just to give it a try. You can also journal your thoughts, feelings, and your changes. You can discuss other ways you can enjoy sex without insertion. You can let your partner know what changes you've experienced and what feels good for you now, and ask them, what feels good for them. And we're going to, in the part 2, we're going to go into some communication strategies. You can reach out to the sexual health clinic and request an appointment with one of the sexual health clinicians. And you can see a counselor and or community sex therapist. And here's the contact information for the BCSC program.